So it's live in YouTube as well now. Okay. So shall we start, because like the time is running? Yeah. Okay. So for headache, no, in the first session, there is a definite question on anatomy. May it be any plexus anatomy or a nerve anatomy individually. So definitely there is a question. One may be asked about a femoral nerve or median nerve, like it depends, and or a recurrent laryngeal nerve, like that. And the question is definite. Whatever sort of the initial question you get, there is a question on anatomy per se. Okay. So Dr. Deepak has already volunteered. So Dr. Deepak, let us all just try answering the questions, even if we don't know, or like we may not definitely be knowing all the anatomical, like lateral, medial, and all, but still try to say all the salient features in whatever nerves which you know. Okay, Dr. Deepak, can you tell something about femoral nerve?
Yeah. So femoral nerve is a branch of lumbar plexus. It arises from the dorsal primary rami of L2, L3, L4.
Okay.
And it passes laterally from the psoas muscle and emerges between the iliacus and the psoas muscle and enter the thigh behind the inguinal ligament.
Mira, I'll give you my iPad now. I have class for half an hour.
Okay. I'll mute the all other participants. Okay, so that.
Thank you.
Okay. I have asked Deepak sir. I've asked you to unmute, so you can unmute yourself.
Yeah. I have
Okay.
So then it enters the thigh behind the inguinal ligament and lies in the femoral triangle, just lateral to the femoral artery. It was separated through the femoral sheath by the iliacus muscle sheath. Then it divides into the anterior division and the posterior division. The anterior divisions had got the muscular branches to the pectineus and the sartorius, and the the cutaneous branches to the intermediate and the medial cutaneous nerve of the thigh. Then the posterior division gives the muscular branches to the quadriceps femoris, and the cutaneous branch is the saphenous nerve, which is the longest branch, which supplies the medial part of the thigh and the medial part of the knee and the medial part of the leg till the medial malleolus.
Okay. So can you explain the structures relationship of the femoral nerve or the femoral triangle?
Yeah, the structures in the femoral triangle lies from medial to lateral femoral vein, femoral artery, and the femoral nerve.
Can you explain to us what are the muscles which are in total supplied by the femoral nerve?
Pardon me?
What are the muscles in total which are supplied by the femoral nerve?
Yeah, femoral nerve supplies through anterior and the posterior division. Anterior division supplies the pectineus and the sartorius, and the posterior division supplies the quadriceps femoris.
Okay. Any other muscles which are supplied by the femoral nerve? It's okay. So I was asked this question in particular, this femoral nerve, and I just elucidated whatever you just told. It arises from this plexus, and you need not. I mean, as you mentioned, it emerges from the lateral border of the psoas major, and then it can the points which you told, no, it's actually which I have described also, except that the saphenous nerve which travels in the adductor canal. So because what they might ask is, they might stop us in the middle at the adductor canal, and they might ask about an adductor canal block from there. So they'll ask what are the various places at which you can block the femoral nerve. So what are the various positions in which you can block the femoral nerve?
So femoral nerve can be blocked first of all at the level of the lumbar plexus itself. Then it can be blocked at the level of inguinal crease when it enters the thigh. Then it can be blocked separately through the saphenous nerve at the level of adductor canal in the mid thigh. Then it can be blocked. The saphenous nerve can be blocked at the level of distal thigh. Then saphenous nerve can be blocked at the level of leg in the mid mid of the lower leg and at the level of medial malleolus.
Like even to the tibial tuberosity, medial to the tibial tuberosity. I think that's what you mentioned as leg, isn't it?
Pardon me? Can you say again?
Like medial to the tibial tuberosity also you can block the saphenous, like subcutaneous infiltration along the tibial tuberosity one, and then at the ankle. That is medial.
Yeah, okay. Yeah, at the level of knee, tibial tuberosity.
Yeah, tibial tuberosity. And like, are you okay to continue with the other nerves also, or shall I ask any other person if they are willing?
No, if anyone, I can, if like I'm fine, and if anyone else
Can
wants to join.
Can anyone volunteer for operator nerve, or if anyone is comfortable with telling about median nerve, or anyone comfortable with brachial plexus anatomy? See, only if you volunteer here, you'll be able to talk there also, because the exam is quite similar to this. Tell me something about brachial plexus. That's what, and they'll stop and look at you to see how you answer. That's all. Anyone else?
Shall I?
Yeah, brachial plexus anatomy. If anyone is not able to unmute yourself, kindly send a text message or chat.
Can I try the brachial plexus now?
Yeah, sure. Brachial plexus anatomy, yes, sir.
Yes, sir.
Sir, you are Narendra, isn't it?
Yes, I'm Narendra.
Yes, sir. Please.
Brachial plexus is formed by C6, C7, C8, and T1. Okay. Sometimes it starts with C4 when we call it prefixed, and sometimes it includes T2 when we call it postfixed.
Okay.
It's formed by the ventral roots of these nerves. Okay. The roots, they join C5 and C6 join to form superior trunk. C7 continues as middle trunk, and C8 and T1 join to form inferior trunk. They lie between the scalenus anterior and scalenus medius. Then they enter the posterior triangle of the neck. The trunks then form divisions. The divisions are formed by, and before they form the division, they divide into anterior and posterior parts. Anterior division of the upper superior trunk and the middle trunk, they form the lateral cord.
Okay.
All three posterior divisions, they continue as the posterior cord, and inferior trunk continues as the medial cord. Yeah. Then these have branches. Well, before that, roots also, there are some branches which arise from the roots and from the trunks. Divisions do not give off any branches.
Okay. Can you tell us some of the branches from the roots?
From the roots, one is long thoracic nerve.
Okay.
No, nerve to serratus anterior.
Nerve to serratus anterior, nerve to rhomboids.
And suprascapularis.
And that's from the trunk, right? So nerve to subclavius and suprascapular nerve from the trunk. Okay. And nerve to rhomboids, nerve to serratus anterior, and some of the branches to phrenic are all from the roots. Okay, and to the anterior scalene muscles, they are from the Can you continue to elaborate about the branches from the each cords?
Yes, madam.
Sir?
Lateral cord gives off musculocutaneous branch.
Okay.
And the
if it's okay for you, can I ask someone else?
Yes,
the branches from the cords. Can anyone elaborate about the branches from the cords? This is like a quick revision of whatever we have read. That's all of the anatomical plexus, so that you do whenever you go and read it about in the book, so that you find it easier. Anyone from
Shall I?
anatomy? Yeah, yes. It's not like whoever. Just come on and then talk.
So
Branches from
the
the
lateral
cords.
cord gives off the branches lateral pectoral nerve,
Yes.
musculocutaneous nerve, and the lateral branch of the median nerve.
Yes.
Then the medial cord gives the branches medial pectoral nerve, medial branch of the median nerve, medial um, cutaneous branch of arm and the forearm, and the ulnar nerve. Then the posterior cord gives of the branches upper subscapular, lower subscapular, nerve to subclavius, then axillary nerve and the radial nerve.
Okay. Nerve to subclavius. It is not. No, nerve to latissimus dorsi, isn't it?
So sorry, nerve to latissimus dorsi. Yeah,
so nerve to subclavius is from the trunk.
Yeah, trunk.
Okay.
Yeah, nerve to latissimus
Okay.
dorsi.
Okay. So can you continue to elaborate about median nerve?
Yeah, so median nerve is a branch of the, it's given off through the median branches. It arises from the lateral and the medial cord. It takes the branches. And then median nerve continues to travel on the anterior aspect of the arm. Then the gives off the branches in the arm to
you can just continue to tell whatever, like it's okay. You just can tell like from the root or from where it arises and how it travels in the arm and how it travels in the forearm and what are all the branches. That's all.
Yeah. So it is given off at the level of the axilla. So from the axilla, it travels from the interior aspect of the arm, just medial to the brachial artery, and then it enters the forearm, and from forearm, it supplies, it gives the cutaneous branches to the, it supplies the motor branches to the flexor compartment of the forearm. Then it gives of the cutaneous branches to the ventral aspect of the palm, that is the medial 3.5 fingers, and the middle palm with the medial 3.5 fingers.
Okay. So in the forearm, no, you have to mention about what are the muscles which are supplied by the median nerve. Like we cannot plainly say like, I understand whatever you have said is okay, but you have to mention about how it travels in the forearm. Like it travels between the FTS and the FTP, and mostly it is adherent to the continue.
So it gives of the branches to the flexor compartment, especially the flexor carpi radialis, and the flexor carpi.
Flexor carpi radialis, digitorum profundus, digitorum superficialis, and and the thenar eminence muscle.
Okay, and then it passes through behind the what we call that in the wrist, flexor retinaculum, deep to the flexor retinaculum, between the peroneal teres and the flexor carpi radialis, and then supplies the cutaneous branches to the palm.
Okay, so it supplies peroneal teres, flexor carpi radialis, palmaris longus, and flexor digitorum superficialis, and the thenar eminence muscle. So, like, even if you forget one of it, it's okay. But on the whole, you should say about these are the muscles which is supplied by the median nerve. And you should say obviously about the cutaneous distribution. Anyone up for radial nerve? There are 9 participants. No, it's okay. Even if it's 10, it's okay.
Shall I try?
Yeah, no problem. Okay. Radial nerve.
I could read as much as I can.
No problem. It is okay. So, it's still okay.
Again,
anyone else
the radial nerve?
Radial nerve.
So again, it is given off in the level of axilla.
No, I mean, whenever you say about a nerve, no, since you started with the femoral nerve, you started correctly. You say the root value of that particular nerve. So you say about the root value of that particular nerve. Say radial arises from continuation of
so the radial arises from the posterior
Yeah.
cord with the root value of T5, T6, T7, C8, and T1.
Yes.
Then it enters the posterior aspect of the arm through and travels through the radial groove, supplying the triceps muscle. Then it gives off a branch on the in the upper in the lower arm. It gives off a branch, supercutaneous branch. Just forgetting the name. Then it divides into two branches, superficial and the deep. Superficial supplies that pronator, and the deep travels in the forearm, and it supplies the extensor compartment of the forearm. Extensor. Then it supplies the dorsal part of the palm and the dorsal part of the fingers.
So as you said, like most of it is okay. It continues as the radial nerve is from the posterior cord, and it pierces the muscular reticulum, and it goes to the posterior compartment of the arm, where it lies above, lies on the triceps muscle, and where it supplies all the three heads, like medial head, lateral head, the long head of triceps muscle, and it is lies in the spiral groove or the radial groove, as you told. And we have to mention like about some 4 or 5 centimeters or hand breadth above the elbow, it becomes crosses and comes to the lateral aspect of the arm, where it lies in the retinaculum, which is or a fascia which lies between the brachialis and the brachioradialis. And then only when comes it when in the spiral groove itself, it gives the posterior cutaneous nerve of the arm and the forearm. And as you told, it splits in the forearm into two, like posterior interosseous nerve and the superficial radial nerve. The superficial radial nerve is purely sensory, and this posterior interosseous nerve is actually supplying the extensor compartment of the arm, and it is mostly muscular. So as you said, it supplies the extensor compartment. That is okay. And you have to say about the sensory supply of the radial nerve in the hand. Like
so
everywhere you should say, yeah, everywhere you should say, but then you forgot in specific about the hand.
So in the hand, it supplies the dorsum of the palm and the back of the dorsum of the fingers.
So this supply is by the radial nerve, and up to this, and all these 3.5 fingers is by the medial nerve, and this by the ulnar nerve, and this by the median nerve. Okay. Yeah, anatomy of this hand, please go through it once again, so that you don't confuse between the palm and the dorsum of the hand. Okay.
Yes, sir. Yes.
Okay. Can anyone elaborate about the anatomy of recurrent laryngeal nerve? No, other than Deepak sir, someone else can try. No, it is just you say it arches around this, it arches around that. That's all. What does it supply? Okay, we can come to plexus later. Anyone about the pharmacology of propofol? Deepak sir, pharmacology of propofol.
Yeah, propofol is a phenolic compound with a structure having 2,6-diisopropylphenol.
Okay.
It is not stable in water, so it is prepared as oil in water emulsion, which contains 1 or 2% of propofol with 10% glycerol oil, 2.25% of 2.25% of 10% glycerol, 2.25% of 1.25% of X-phosphate, and 2.25% of that.
No problem. You go ahead. We will discuss about it later.
Yeah. Then sodium hydroxide in the water. So with this, it has got a pH of 11 with the pH of 6 to 8.5 with a pK of 11, and that makes it almost completely unionized in the solution, and that favors it makes it more lipid soluble and rapid and fast acting. Regarding its pharmacokinetics, it is rapidly absorbed. It is like in one brain on circulation time, it produces the unconsciousness. Then it is 98% protein bound, and
Okay.
then the volume of distribution is 4 liters per kg.
Okay.
Volume of distribution 4 liters per kg with a clearance of 30 to 60 ml per minute per kg. And with this faster clearance, it has got a faster onset of action and a rapid onset, which makes it ideal agent for the SIVA. It will be used as SIVA agent. Then its pharmacodynamic effects are on the CNS. It reduces intracranial pressure. It reduces cerebral metabolic rate of oxygen. It reduces the cerebral blood flow. It also causes has anti-epileptic effect, but some studies have mentioned it as causes myoclonic-like movement. So it may act as pro-epileptic also. Then in the CVS, it reduces the vascular resistance, so decreases the cardiac output and the blood pressure. It also has a vasodilatory effect because of production of nitric oxide. Then regarding the respiratory system, it blends the response to the blends the response, stimulatory response, and causes apnea. And it is ideal agent for putting igel in the patient without having muscle relaxants because it blends the airway reflexes. Then in liver, it decreases the liver blood flow, and then renal also decreases renal blood flow. But it is safe to be given with the patient having liver disease and the renal disease because it does not stimulate. Then prolonged infusion can cause propofol infusion syndrome. So it should not be used for prolonged infusion for more than 48 hours.
What is the dosage up to? I mean, what is the dosage which is proposed to cause?
So the dosage for induction is 1.5 to 2.5 mg per kg. Then the maintenance dose is 5 to 12 mg per kg per hour as an infusion.
Okay. So did I interrupt you in the middle when you were talking about propofol? You can continue to talk about propofol.
Okay.
I'm sorry, I interrupted you in the middle, I think. Yeah.
No. Actually.
Okay. So you have told about the dynamics. Then you have to say about the uses and contraindication and adverse effects. So you mentioned it, no? So you can tell us uses like, as you told, for induction, for sedation.
So it can be used for induction. It can be used for procedural sedation also. Then it's ideal for the use to be used as SIVA. It has anti-emetic properties also.
Yes.
Then
and if at all you are okay, you can tell about contact sensitivity half-life of propofol. Say that even if you give it as an infusion, the contact sensitivity
half-life. Because it has a rapid onset and faster onset, faster elimination, its contact sensitive half-time is less with the infusion. With a 20-minute infusion, with a 2 hours infusion, it's 20 minutes. With an infusion of 6 hours, it's 30 minutes, and with an infusion of 8 hours, it's 50 minutes. So the contact sensitive half-time is favorable to be used as an infusion agent.
Okay. So propofol constituents, no? It is 1% propofol, 10% soybean oil, 1.25% purified egg phosphatide, and 2.25% glycerol, 2.25% glycerol. Okay. So we need not forget this, and I'm really not sure if I would be able to remember whatever the clearance values which you have told. Through my Viva, I just told it's rapidly eliminated. I wasn't asked about propofol yet, but I cannot remember the values like 42, because it's only induction agent. No, you were able to remember, but I'm not sure if anyone is able to read it. It is well and good, but even if you're not telling it in like 40 to 60 ml per that clearance, and you can just say it has got extensive volume of distribution or less volume of distribution, and you can say if the drug is like extremely protein bound, and we need to know this protein bonding for sure. So in the pharmacology, they'll ask about what are the drugs which are extensively protein bound and which are not that much protein bound. So you can write it down when you even read it, say, and like there may be an initial question itself saying that, see, this is the protein, the patient has got an albumin or alpha glycoprotein so and so, and what are all the implications in the perioperative period for you as a perioperative physician or an anesthetist? What do you think, or how can this affect the drug metabolism and system? Like that, there can be a question. There was a question about protein binding to us, so they just asked about what are the drugs which has high protein binding, and if the protein binding is less, what are the effects you expect? So this is a very common question about protein binding, so we should know as what you have told. And you can categorize the induction agent itself as high protein bound or low protein bound, and you can remember it very easily. Okay. Anyone up for thiopentone? Propofol infusion syndrome, we were talking, what is the dosage at which it causes propofol infusion syndrome, and what are the features of propofol infusion syndrome? Anyone? Or Deepak sir, if you're okay, you can just go ahead with propofol infusion syndrome.
So propofol infusion syndrome is expected to have, if the infusion is prolonged for more than 48 hours with a dosage of more than 12 mg per kg per hour, it presents with rhabdomyolysis, then lactic acidosis, then
what is the dosage you told, sir?
More than 12 mg per kg per hour.
More than 4 mg per kg per hour for at least 48 hours. And it was initially reported in children only. So some had unexplained metabolic acidosis and rhabdomyolysis and bradyarrhythmias. So when poked, it was because of the hypertriglyceridemia or hyperproteinemia, which is associated with propofol. And that is how that propofol infusion syndrome evolved. Rhabdomyolysis, acute kidney injury, unexplained bradyarrhythmias, and unexplained metabolic acidosis. Okay.
Yeah.
Okay. Okay. So also for sedation, now you can mention about the dosages like 50 to 100 mg per kg per minute dosage, and adverse effects like or contraindication, you can mention any patient who is in a hypovolemic shock, or any patient in whom already there is a compromised cardiovascular system. In them, we'll be very using propofol very guardedly. That you can mention it in that way.
Okay.
Okay. Okay.
Thank you.
Anyone, I mean, this is a very favorite question for all. Anyone who can tell about the intra-arterial injection of thiopentone and its management? This is very common, no? Anyone can volunteer. Deepak sir is power. He has been answering for more than 30 minutes, I think. Yeah, he has been answering for almost 20 minutes.
Can I try one?
Yeah, it's just a discussion. It's not about any. Only if you open up now, no, you can actually bring it up later in the Viva as well. Yes, sir. Please go ahead.
Intra-arterial injection of thiopentone would present as severe pain and clenching of the distal limb.
Yes.
The thiopentone may crystallize and block the vessels. If not treated promptly, it may lead to limb loss.
Okay. How can we ever treat the intra-arterial injection of thiopentone?
First of all, we should avoid antecubital fossa veins, which are most likely to result in intra-arterial injection.
Okay.
Once the drug is given and pain and or blanching is noticed, do not take the cannula out.
Okay.
In still heparin, instill piperine.
Okay.
Give a brachial plexus block, warm the limb, run saline.
Okay.
If it does not resolve, if it doesn't resolve, maybe some vascular graft may be tried.
So as you've
I'm
told,
not sure of this
it
point.
is Yeah. I mean, it is because of the crystalline formation, because the pH of thiopental is around 10.9, and it crystallizes if you have given it intra-arterially. So do not remove the cannula and give saline, give epaverin, or give heparin or phentolamine or any alpha blocker for that sake, and pepaverin as well. It's not a it is a stellate ganglion block because it produces a sympathectomy in the upper limb. So that can ensure the prevent the vasospasm which is occurring and can help save the limb. Can anyone tell what are the side effects, or how do you ensure to say that the stellate ganglion block has taken?
Horner syndrome.
Yeah.
Just like Horner syndrome.
Yeah, Horner syndrome. Yes.
Ptosis, meiosis, and ophthalmosis.
Okay. Can anyone come up with yeah? Can anyone come up with the indications for stellate ganglion block? It's though I'm jumping out of topic. No, you can get this as a question as well. So any regional pain syndromes for CRPS for upper arm, and any pain syndromes for that sake for the involving the upper arm, which has a sympathetic mediated phenomenon, and for anesthetic indication, it's an intra-arterial injection of thiopentone on any patient who has got a recurrent electrical storm or a recurrent VT or VF which is not responding to shock even after 3 shocks or so. So that time also we can give a stellate ganglion block. So for in view of pain, if you are in the third session and if you have some question related to pain or a complex regional pain syndrome in the upper arm, you may be asked about stellate ganglion block. So though it is deviating from the topic for today, still this is a important question for discussion in the third session of your Viva, which is pain management and anesthesia. So we need not forget to read about stellate ganglion blocks as well. Stellate ganglion, celiac plexus block, or splanchnic nerve block, like that they may ask in the pain management. Okay, so Deepak sir, as we were discussing propofol, one important point which we have forgotten is the mechanism of action of propofol. So if at all we take any drug in pharmacology as concerned, you actually divide your answer into segments, and Deepak sir has excellently segmented it. So whenever you talk about a drug, if it's propofol, you say it's 2,6-diacylpropyl phenol, and what are the constituents in it, like 1% propofol, 10% soya bean oil, 1.2% purified egg phosphatide, and 2.25% of glycerol, all that. And once you finish that and you say what are all the available formulations, like it's available as an emulsified preparation, 1% preparation. And next, this is how I prepared. So the next comes the mechanism of action. Say it's GABA mediated, and it is potentiating the action of GABA. Then you jump on to kinetics as he said, and then come to dynamics. And whenever you answer a particular drug, say thiopentone or propofol, you divide your answer as CVS effect, CNS effect, RS effect, and if at all there is an effect on liver, kidney, or any other specific effect, like in propofol, you can add about the anti-emetic action. So that's one thing which is very notorious for propofol. So if it is thiopentone, this intra-arterial injection is notorious, and like all those CVS, CNS, and RS effect, and say liver or any other effect which you want to add. Then you say about the uses, like we know that it is used for induction, but then you have to convey that it is used for induction. So you say that it is used for induction. If at all it is thiopentone, you say it is used for induction, like this, and used for induction. And sometimes in a very rare situation, thiopentone is also used for a barbiturate coma in case if there is a severe ICP rise. So you can say that also as a use. In a contraindication or an adverse effect, you can say that it reduces the blood pressure and raises the heart rate, and hence it cannot be given to a patient who is already hypovolemic, like that. Okay.
Yes. Okay.
Okay. Anyone else? No? Can you come with? Someone can talk about ketamine. Only the salient features of ketamine. So whenever you say the preparations, whenever you say kinetics, you will add the dosage also to that.
Can I
Sachin.
talk about
Hello.
Yeah. Anyone. Yes, sir. Yes, sir.
Yeah, can I try?
Yeah. I mean, this is not really about judging or anything. This is just about you opening up yourself about some particular drug. That's all.
Okay. Yeah, I'm Dr.
Yeah.
Ranjit. Ketamine, it's a phencyclidine derivative. It is a color coming as a colorless solution, available as preparations of 10 mg per ml, 50 mg per ml, and 100 mg per ml.
Okay.
It is used as induction agent. The common routes are intravenous, intramuscular, intrathecal, and other routes of usage are epidural, oral, and rectal.
Okay.
The mechanism of action, it is a non-competitive inhibitor at the NMDA receptors.
Okay.
And it has some effect on the mu, delta, and kappa receptors, and it has got a decreased, it also causes a decreased uptake of noradrenaline. Preservative is 1 in 10,000 benzethonium chloride. The pH is 3.5 to 5 and pK is 7.5.
Okay.
And the two enantiomers available are and S enantiomer. So the S is having better potent effects, like less side effects of less emergence, less hallucination, and it is more potent.
Yes.
And the usual doses are 1 to 2 mg per kg as intravenous dose for injection. And analgesic dose is around 0.2 to 0.5 mg per kg body weight.
Okay.
And IM doses, we give higher doses like 5 to 10 mg per kg. Then the volume of distribution is around 3 liters per kg. And it is metabolized in the liver to metabolism. First absorption is like 20% oral bioavailability is there. Distribution, it is metabolism, it is metabolized in the liver to norketamine, it is 30% potent. Half-life is around 3 hours. Then we are going to the systemic effects. CVS, it causes increase in heart rate, increase in the cardiac output, increase in the systemic vascular resistance, increase in BP. It decreases the uptake of noradrenaline, so that is what is causing the increase in the heart rate and increased sympathetic stimulation. Respiratory system, it causes bronchodilation and direct sympathomimetic stimulation of the respiratory system. CNS, it is a specific feature for it is dissociative anesthesia. Along with that, increases all the pressures, that intraocular pressures and intracranial pressures. It can cause emergence and hallucination, which can be decreased by the co-administration of benzodiazepines. Then it can also cause post-op nausea and vomiting, and it increases secretion, so increased salivation, and that is one side. And contraindications of ketamine, it is not it should not be used in case of the increased intracranial pressures, intraocular pressures, and in cases of non-case of ischemic heart disease. So because it can increase the heart rate and cause that demand supply mismatch. And indications, it can be used in patients with in shock and with decreased BP.
Okay. You told about the intramuscular dosage. It's somewhere around 10 milligram per kg, but then it's 4 to 6 milligram per kg. In your flow, you told about it's 10 milligram per kg. Okay. That's about ketamine. Yes. Yeah, most of it you covered. No issues regarding that.
Okay. Thank you.
Okay. Yeah. When you've read so well, then it's okay. Okay.
No, anatomy, I didn't read anything about that.
No problem. Any one of it is fine. No problem. It's okay. And preemptive, you told about it. So 0.25 milligram per kg. And
it can also be used in opioid tolerance cases.
And pain management recently that is getting its use. And be very, if they ask about ICP and ketamine, no, there are emerging evidence which says ICP is not that much raised, and there are no much of an adverse outcome when you give ketamine in a patient who has got a raised ICP. So, like if they are very particular about it, you can just go and say like there are evidences supporting this, there are evidence supporting that, though they may not like poke their nose too much into it. But then when they ask, like you say you have evidences for both, like that. So whichever you have read in particular. Okay. So anyone for midazolam? Pankaj sir. Anyone for midazolam? No, midazolam, like you can just say about benzodiazepines, like how it acts, and in specific for midazolam, you can say about anyone. No, it's the same, no, like barbiturates.
I haven't read it, but I can.
No, you can just say like midazolam is what
so
it is.
Midazolam is a benzodiazepine derivative.
Yeah.
It is an short-acting benzodiazepine.
Yeah.
Then it has it shows tautomerism with a ketoenol transformation. In the solution, it says it has an ring which is opened up, so it is mainly in ionized form, and when it is injected, then it converts into the enol form and
lipid soluble form. Yes.
Yeah, then it becomes soluble form. It can be then regarding the pharmacokinetics, it is mainly it absorbs. It has rapid onset and rapid offset of action. Then it is metabolized mainly through the liver and it excreted through the kidney as glucouronate conjugation.
It's metabolized to hydroxymidazolam. Yes, as you told, the elimination half-life is around somewhere around 1.5 hours to 3 hours. Whereas for diazepam, it is around some 20 hours.
And it got accumulated if the patient has got renal failure. So it should be avoided in those patients. Then regarding the pharmacodynamics in the CNS, it reduces the threshold for the seizures, so it is used as an anti-epileptic. Sorry, it increases the threshold of seizures. It is used as anti-epileptic agent. Then it reduces the cerebral blood flow. Then in the CVS, it decreases the XPR and causes decrease in cardiac output and decrease in blood pressure. Then in the respiratory system, it causes respiratory depression, so it should be avoided in elderly patients. Then the doses, it is given in the sedation as 1 to 2 milligrams of IV as a sedation. Then it can be used as it can be used in the dose of 1 to 2 milligrams as anti-anxiety. And if we are using it as a sedation, we can give it in higher doses of 4 to 5 mg. Then
that's how it goes. So you as Dr. Orvis had mentioned, now we also have to tell about the routes of administration, like there is oral midazolam, IV midazolam.
Yeah, so the different routes through which we can use is intravenous, intramuscular, and the oral preparation.
Oral formulations are also available. So procedural sedation and for induction of anesthesia. So that is how the uses evolve. And as you told, you have covered about the kinetics and the dynamics part. And as usual, we both have forgotten about the mechanism of action.
Yeah, so it acts basically through GABA A receptor.
Yeah.
On the beta unit subunit of the GABA A receptor.
Yeah. So we all assume that we know, but then we do not reproduce it in the exam. So that whenever you read pharmacology, you have this format for yourself, and you recite all the drugs whenever the viva goes in the same manner. Even if you forget one topic, it is okay. Like they will not punish us if you don't say about mechanism of action of midazolam. But then if you continue, the pharmacology session will be like, say something about midazolam. Once you finish midazolam, or if you don't finish midazolam, they'll jump to the dexmet. You say something about dexmet, then even if you do not finish, they'll keep jumping on from drugs to drugs so that they cover at least some 10 drugs. So if you in total do not tell the mechanism of action of 10 drugs, then it is like they question us about how we have prepared. But if you miss one drug, that doesn't bother. That's what I think, because in that adrenergic surge, I might have forgotten, but then that did not cost me. So like each and every drug, if you memorize it in such a way that if they ask about adrenaline, you will say like it is sympathomimetic agent. It is available as adrenaline bitartrate. It is available as 1 milligram per ml solution. Then this is the mechanism of action. It acts on the alpha receptors and the beta receptors. Then its action on the heart, action on the bronchus, action on the GIT, then action on the brain. All these are so and so. And this is the use, and this is the contraindication. So that is how the use, that is how it goes. Okay. So back to plexus anatomy. Can anyone enumerate about the sacral plexus anatomy? No, this is for definitely we'll get a question either based on sciatic nerve or recurrent nerve, pudendal nerve, femoral nerve, ulnar median, all that. There is no doubt in it. There is a question definitely from anatomy. So sacral plexus, anyone? They will not ask about like it passes through medial lateral, but then if you say sciatic nerve, the roots value or this and this, and it emerges from the greater sciatic foramen. From there it enters, from the pelvis it enters, then it lies between the ischial tuberosity and the greater trochanter. Yeah, you can continue. I'm not going to answer.
Yeah.
You continue.
So
if you're okay, you can continue, sir.
Sacral plexus is formed by the anterior primary rami from the contribution from the L4, then the whole anterior primary rami of L5, S1, S2, S3, and some contribution from S4.
Yeah.
So the L4 and L5 forms the lumbosacral trunk, which continues and joins the S1, and they altogether forms a common trunk, which passes through the greater sciatic foramen, and it divides into terminal branches, sciatic nerve and the pudendal nerve. So the sciatic nerve has got the root value of L4, 5, S1, S2, S3, and it emerges in front of the pectineus muscle and goes into the thigh passing between the greater tuberosity, greater trochanter of the femur and between the ischial tuberosity, and then it enters the posterior part of the thigh, and just proximal to the popliteal crease, 6 centimeter proximal to the popliteal crease, it divides into its terminal branches, the medial tibial nerve and the lateral common peroneal nerve. Then the tibial nerve gives of the branches, the posterior tibial nerve and the posterior tibial nerve and the sural nerve, and it ultimately divides into the lateral and the medial plantar branches, which gives the cutaneous branches to the sole of the foot. Then the common peroneal divides into the superficial peroneal and the deep peroneal nerve. Superficial peroneal supplies basically the dorsum of the foot, and the deep peroneal supplies the cutaneous innervation between the first and the second toe. The common peroneal nerve supplies the peroneus longus and the peroneus brevis, which causes the foot to dorsiflex in the everts, and the tibial nerve causes the foot to plantar flex in the inverse.
Okay. So on the whole, described the whole nerve, that is fine. So if they ask about what are the nerves from the sacral plexus, also we must be able to tell, like say superior gluteal nerve, inferior gluteal nerve, sciatic nerve, and the pudendal nerve. And anyone up for lumbar plexus formation in the nerves from it?
May I again?
Yeah. If you're okay, you can continue.
The lumbar plexus arises from the anterior primary rami of L1, L2, L3, and L4, and sometimes contribution from the T12. So the L1 with the sometimes contribution of T12 L1 has got an upper division and the lower division. Upper division with contribution from the T12 forms the ilioinguinal and the iliohypogastric nerve. The ilioinguinal has got the iliohypogastric has got the root value of T12 L1, and the ilioinguinal has got the root value of L1. Then the L1 and L2 together forms the lateral cutaneous nerve of the thigh, Then L2, L3 forms the L1, L2 forms the genitofemoral nerve, and L2, L3 forms the lateral femoral
nerve of the thigh.
And then the L2, L3, L4 has got two divisions: the ventral division and the dorsal division. Dorsal division forms the femoral nerve, and the ventral division forms the obturator nerve.
Yeah. Can you continue to tell about the obturator nerve?
Yeah. So the obturator nerve supplies basically the medial part of the thigh. It is in the muscular branches to the adductor longus, adductor brevis, and the pectineus. That much.
Okay. I don't think obturator nerve supplies the pectineus, but then it supplies the adductor longus, brevis magnus, gracilis, and the obturator externus.
Pectineus supplied by femoral nerve.
Femoral nerve, it's not supplied by the obturator nerve. So obturator externus and internus is supplied by sciatic nerve. So obturator externus, adductor brevis, adductor magnus, and gracilis are all supplied by obturator nerve. And for both obturator nerve and femoral nerve, or femoral nerve, we can say it supplies articular branches to the hip and knee. That holds good for the obturator nerve also. It supplies articular branches to the, so even if you say median nerve, any nerve which crosses a particular joint will actually supply an articular tube to that particular joint. That is a Hilton's law. So if median nerve crosses the wrist, then it supplies the wrist as well. So it provides the articular branches to all those. And when it comes to the obturator nerve anatomy, we should say it passes in the obturator foramen. Okay.
Yeah. Okay.
Okay. So you should not forget it about the obturator foramen. That's why I kept this diagram. And because you told about the nerve supply, I mean, it supplies the anteromedial part of the thigh. So that is about the obturator nerve. So what is the significance of obturator nerve in TURBT?
So the obturator nerve in TURBT, then if the mass is on the lateral wall of the bladder, when the surgeon is trying to remove that part, that part is supplied basically to the obturator nerve, and it got a sudden jerk. The patient may had a middle adductor compartment got stimulated, and the patient can have perforation of the bladder.
So it is imperative to perform this block as well, and we can as well say it is like divided into anterior division and the posterior division and all that when it comes to, if they ask in detail about the obturator nerve. Okay. So can anyone tell about the recurrent laryngeal nerve? Because this question was asked, that's why I'm pertinent about recurrent laryngeal nerve. And in the intention, my colleague forgot to say about which it hooks around. Anyone? Recurrent laryngeal nerve? So like we need not describe about the vagus nerve in total. If they ask about, can you tell me something about recurrent laryngeal nerve? So you can say it like it's a branch from the vagus, and what it hooks on the left side and what it hooks around on the right side.
That I don't know.
In the left side, it hooks around the arch of aorta, and on the right side, it hooks around the subclavian artery, and it climbs up way to the larynx. Can anyone tell about the muscles supplied by recurrent laryngeal nerve?
Yeah, so the recurrent laryngeal nerve supplies all the muscles of the larynx, except the cricothyroid, which is supplied by the external branch of the superior laryngeal nerve.
Okay, so and it supplies the sensory sensation is below the vocal cord. The sensation is
below the vocal cord.
Because below the vocal cord, it is supplied by recurrent. That is what they expect. But then, like, if they ask about what does it hook around, then one should not fumble upon them. That's why I put this question, because it was asked in the examination. Okay. So can anyone tell about
left side arch of aorta, and
right
the right side the subclavian artery.
It is subclavian artery.
Okay.
So anyone for Dexmed? Just we can try Dexmed so that it ends the session, because I think I covered the anatomy of all the things. And there are something about cranial nerves, but personally, after recurrent laryngeal nerve, I don't think they have asked about any cranial nerves per se. If at all they want to ask, they may ask about facial nerve. But to whomever I inquired, no, they were particular about femoral, operata, pudendal, and all those nerves. In the cranial nerves division, the one which I know that was asked was the recurrent laryngeal nerve. Anyone for dexmedetomidine as an, though it's not an induction agent, it covers, like, we are not using it as an induction agent. It comes mostly in the induction agent segment only. No? Dexmedetomidine.
Dexmedetomidine is a central alpha 2 antagonist. So central alpha 2 antagonist.
Antagonist or agonist?
Yeah, sorry, agonist. Central alpha 2 agonist.
Yes. Yes.
It is a congener of clonidine.
Yeah.
With more alpha 2 action than alpha 1.
Yeah.
Then I know the dose, the induction, like the bolus dose, we have to give around 0.7 to 1.2 milligrams per kg in 10 minutes, followed by
microgram per kg. Microgram per kg.
Sorry, microgram per kg.
Yeah.
In 10 minutes, followed by 0.5 to 0.7 microgram per kg per hour. Sorry, per minute. Per microgram per kg per minute. Then the side effects, they can have hypertension in the bradycardia with the arrhythmias. So we have to keep a watch on that.
Okay.
So it can be used it does not cause respiratory depression. So it's an excellent agent to be used as sedative, and it has got analgesic properties also. So it can be used as analgesic also.
Yeah, as it is used in opioid sparing anesthesia, this is what is most commonly used. Okay.
And
so
it does not accumulate with the infusion. So offset time is passed. The patient wakes up immediately as the infusion is stopped.
Okay. So when you say about CVS, you tell them about heart rate, blood pressure, and sometimes in the blood pressure, no, it can cause paradoxical hypertension as also. So because of the initial alpha-1 action, they can have paradoxical hypertension in the initial period followed by hypotension. That is one. And whenever you say about CVS, or whenever you say about CNS, because we are talking about the induction agent as a whole, we tell about ICP, cerebral blood flow, and cerebral metabolic rate of oxygen. And if it has got any potential to any seizure threshold, if it is potentiated, or whether the threshold is lowered or whether the threshold is maintained. Okay. So if you do not forget these four, we have got 4 important points for the CNS as well. And as you told for dexmedetomidine, yes, it is a conscious sedation agent, so it does not cause any, like, it is an agent of choice for any patient in whom we did not have a respiratory depression. Okay. So dose depends, like if you are going to give for a sedation, it is around 0.5, and even up to 4 mics they have used, but then what we routinely use is around 0.5 to 1 mics or 0.5 to 2 mics per kg. And coming to the routes of administration, it is like nasal, intrathecal. So though it is FDA not approved, they give it epidurally, and intranasal dexmed also they are giving. So route of administration of dexmed we need to be aware of. And side effects, as you told, it is like it causes bradycardia and hypotension. So in any patients, as it follows. So anyone up for etomidate?
Hello.
Yeah. Yes, sir.
Yeah, I can.
Yes, sir. Yes, sir. Please.
Etomidate, it's a IV. It's an IV induction agent. It is an imidazole derivative. It is available as a solution of 0.2% solution, which has got a with propylene glycol as a solvent.
Okay.
The pK is around 4.2. It is hydrophobic. at the physiological pH. So it is more lipophilicity, and so it is more absorption. Then the mechanism of action, it is a GABAergic in the CNS. And the CNS, the main thing is it decreases the ICP but maintains the cerebral perfusion pressure.
Okay.
It is beneficial in cases, beneficial, and it is increase in cerebral oxygen supply to the and it decrease. Other thing is it has got anti-conventional it has got two effects on one thing. It can cause grand mal seizures, and it has and increase EEG activity, and it has also got anti-conventional properties. It can be used in status epilepticus. In CVS, it is the most cardiostable. Minimal changes in heart rate, cardiac output, and stroke volume, but mean arterial pressure, there is a change of around 10 to 15% because of the decrease in SVR. And there is there is no analgesic property for etomidate. Respiratory system, less apnea, less ventilation suppression.
Yes.
And whatever is, there's a transient hyperventilation followed by apnea in some cases. There is no histamine release, so there is no bronchospasm risks for etomidate. Then other thing is then main thing is the it can side effects, more side effects with etomidate. One is it can cause involuntary movements or myoclonic jerks. Nausea, it can cause more nausea and vomiting. Other thing is, main one is cortical suppression in all patients. Even with a single use, it can persist even more for more than 24 hours, mainly due to the inhibition of the 11 beta hydroxylase and 17 alpha hydroxylase enzymes. Other side effects are antiplatelet activity. It has got antiplatelet activity. It causes venous thrombosis. I think that's and the newer preparations available are like carboetomidate and methoxycarbonyl etomidate. Newer preparations are available. Okay. And sepsis, and the main disadvantage is to not use in sepsis patients or in hemorrhagic patients where the suppression of cortisol is going to be detrimental. Okay. So, and the use is always for the induction of anesthesia. Induction, I just 0.2 to 0.6 mg per kg IV can be used. Okay. And one more thing which they would have given in Miller is the treatment for hypercortisolemia. Hypercortisolemia, you can use it. So you can use the side effect can be used as a treatment option. Treatment option. And the single dose of etomidate can actually suppress the serotogenesis for up to 72 hours. Okay. So 72 hours. And
maybe it's mentioned differently in different books. Some books mention it 8 hours, some books mention it 24 hours, and some books what Miller, I read from Miller only, it says it's 72 hours. Etomidate can suppress some books. I mean, even if you stay around some 24 hours, no, they are happy with it. But then if you say 1 or 2 hours, then they're not happy. Yes. Like you should know, definitely it is for the action is for real and it prolongs at least for 1 day. So that we must know. And also that some of the members can be asked about in the later session, in the ICU session, about some studies or trials, and that is given in master pass, I think, like crash 1, crash 2, crash 3, and like that. So Miller also gives somewhere around some study about etomidate and sepsis, like corticus trial. So one can go around, look in Miller for such trials. Though this trial may not be asked in particular, but crash 1, 2, 3, all those can be asked. One thing to notice in the ICU session, there is a question for this is there are some definite questions. In that one definite question is ICU and anesthesia scoring systems. So I've updated my class, like in the later date of my class also. There is a class on anesthesia and ICU scoring systems. In the ICU scoring systems, I was in particular asked about Apache, SOFA, QSOFA, RCRI, revised cardiac risk index, Goldman risk index, ASA. We'll think like ASA is like, but then when they ask, they will give you example and they ask about what is the ASA grading of this patient. So for upcoming classes, before even I'm just saying these are all things which they will ask, so that if you have booked your exam prior to our 6 month schedule, it will be helpful for you.
So one definite question in the ICU part is anesthesia and ICU scoring system. Okay.
Okay.
Okay. So routine, what are we use, those scoring systems please go through. Okay.
Okay.
I think
Yeah,
that is all for today. We'd expect more volunteers in the upcoming session as well, because in the exam answering for 20 minutes is okay, but then if it is everybody should get benefited. That is why, like, although this class is based on a very short notice, you have upcoming classes on ventilators and also with appropriate time duration, so that you prepare yourself, and when they ask, you open up and then you talk. That is how, even they will not punish us for if you don't answer one question, but then if you continuously don't answer, no, then that is what keeps punishing us in the examination. Okay.
Okay.
Okay. And the protein binding, you will be asked about this in the, so we were talking about midazolam, right? That is also one induction agent which got a high protein bonding, somewhere around 95 to 90%. So they had given an example wherein they say a CLD patient or any patient who has got a decreased protein binding, and how will you titrate your dose, or what do you expect with warfarin, amiodarone, like that, which has got more protein binding, and interactions among amiodarone and warfarin, what does it cause, like that. All drugs can be read from our standard books as well, and some they expect from Smith and Pinnock also. That in that book it's quite easy, Smith and Pinnock. Whatever MD books which you have read, that is also fine. And they are very particular about, I mean, they don't stick around one drug in pharmacology, they keep jumping. Even if you answer or don't answer, like if I am in the middle saying that propofol is 2,6-isopropyl phenol, okay, then tell me about Dexmed. It's not, I would never have finished propofol only, but then they'll step on to the next drug, so that we'll not be getting over with one drug alone. It is like 10 or 15 drugs in total which they ask. So even if you miss one thing about a drug, that's okay. Like you can tell, and if you don't know what they are asking, you can very well say, sir, I don't know. And in opioids, no, there is like in opioids, their favorite question is, what is the IV dose equivalent of an oral morphine, or oral dose equivalent of an IV morphine, like that. So opioids, they are very, I mean, in that segment, they are very fond of. And what is an opioid? What is an opiate? All that is there in Smith and Pinnock, and they definitely ask those things. Okay.
Yeah. Okay.
Shall we end here? Okay. Kindly give us the feedback in the link which we are providing. And I think there are so many who have had troubles in logging in. So next time we can start the session somewhat quite early itself, so that we don't find this trouble again.